Greetings and good evening to everybody and welcome. So I'm going to formally begin now by welcoming you all to tonight's webinar from the Create Centre at the University of Sydney. Can I begin by acknowledging that wherever we are joining this Zoom from, we are joining from unceded Aboriginal land. I'm joining you tonight, unusually from myself, from Ngunnawal land in the Australian Capital Territory, and many others may be joining from Gadigal land or all around Australia. I invite you to acknowledge the country that you're joining from in the chat. Wherever you're joining from, we acknowledge that this amazing country has been looked after by its traditional custodians who have never ceded it and for whom we have learned that culture and creativity are never separate from health and well-being. And in the spirit of the wisdom of our First Nations leaders and elders, we acknowledge all Aboriginal people who are joining us tonight and pay respects to elders past, present, and emerging. Thanks so much for your acknowledgement of all that this custodianship has brought us and continues to infuse our conversation for tonight. We are really proud as members of the Create Centre. So for those who don't know, the Create Centre at the University of Sydney is a centre that encourages creativity in research, engaging the arts to transform education, health, and well-being. And the Create Centre has been in establishment for a few years now to explore in creativity research the role of the arts in creative education, health, and well-being, and to explore how the arts transforms all level of education from early childhood through to higher education. We are a multidisciplinary centre with a wide variety of different projects across multi-arts, different aspects of the arts. But in all of the various projects that we do, which you're very warmly invited to look at through the link that Anna will have placed, I think, in the chat. You'll have to scroll up through the acknowledgements of country to find it. You can see the range of projects that we work on, in all of which we like to explore the central role that the arts can and should play in the lives and learning of all people in Australia. What I'd like to do now is to introduce our presenter tonight. And the fact that we have a really large number of registrations for tonight is testament, I think, to the enormously high regard with which so many people hold Professor Genevieve Dingle. For a long time now, those who've worked in the arts and health space have been really inspired by Jen's leadership and research on music and well-being, and her early interest and carrying forward exploration of how we might use social prescribing to enhance people's access to the arts and in particular to music in support of their health and well-being. Jen has been a national and international leader in this space and has not that long returned from connections to centres for social prescribing research overseas. So we're really privileged to be able to have her time tonight to present some of her own research in this space along with some of her colleagues. So without further ado, Jen, I mean, there's a lot of things we could say about you, but I think we all want to hear what you have to say about your research. I'm going to hand over to you.
Yes, so thank you so much, Claire and Anna, for the invitation, and thank you everybody for giving up your Thursday evening to join us today. I will be speaking about social prescribing and the arts on prescription in particular for mental health, although it is much broader in application than that. If you have any questions or would like to discuss anything that we're talking about later, my best contact is the email on the slide there, and I also am fairly active on social media as well. I also would like to echo the acknowledgement that Claire has offered. So I'm up here in Meanjin in Brisbane. What you see on the slide there is our University of Queensland reconciliation artwork, a guidance through time. And so I would also like to pay my respects to the traditional custodians of the land here that I'm joining you from, but also extend that respect to all the lands that you're joining us from, in particular the Gadigal people in the greater Sydney area, and pay my respects to their ancestors and descendants who continue cultural and spiritual connection to country. So I'm just going to start off with quite a bold statistic from the Australian Bureau of Statistics. 8.5 million of us as Australian adults will have a lived experience of mental illness in our lifetime. So I think that's just something that bears saying at the start of this talk. And I'm going to sort of mention here some work by Oliver Sacks, who was a person I really followed and read a lot of his work when I was early in my training as a psychologist. So he wasn't a psychologist, he was a neurologist and obviously a writer. But in his memoirs, Oliver Sacks spoke about his brother Michael's schizophrenia, and he emphasised that although the hallucinations and delusions that Michael experienced were very distressing, it was in fact the social aspects of the illness that were even more devastating, both to Michael but also to Oliver. So he described, that Michael really didn't have any social life. He really only knew people in his job and in the family, and he didn't really have friends, and he was very lonely and isolated in his own world. So the way he described that was really something that made me think. We get so concerned about, I guess, managing these hallucinations and delusions and forget about the whole person and what their experience is like, and just relating to others around them. And, during my own training as a psychologist and working in psychiatric hospitals sort of in the mid-90s to mid-2000s, my training was really dominated by individually focused, deficit-based conceptualizations of mental illness. We really were trained to find out what was wrong with people and to try and fix it. That was the overall ethos. And there was no mention at all, as far as I can remember, of social determinants of health. Mental health services were dominated by the medical model. Public mental health was really only for the acutely unwell, so people who were a danger to themselves or others. Private hospitals were funded by, of course, private health insurance, and you actually had to have a diagnosis to be able to even get any funding under that system. And there was no funding for anyone else. So your family, your partner, your children, your community support, none of that was funded. It was all based on that one individual with their diagnosis. And of course, we've seen a huge domination in this field of big pharma and the interests of the medical model and medication. And I just was thinking through, I did a lot of group work in hospitals during that time. So most of what I did was actually in groups. And I really got interested in, what is happening in groups, and maybe people could get these sorts of effects through naturally occurring groups closer to home that were not about their diagnosis and not a specific support group for, depression or addiction or whatever it was that they were facing. But could their own naturally occurring groups also help mental health and social inclusion? So I'll just show you, I've gone through a huge amount of these sorts of studies, but I'll just give you a snapshot of a few that were sort of the backstory. So this is the Upbeat Arts Queensland evaluation project. So this was around sort of 2015 to 2017. It was led by my then PhD student on the left here, Elise Williams, and co-supervised by Professor Yolanda Yetten, who's a social psychologist. It was a one-year prospective study with 59 adults who had ongoing mental health problems who joined the first 2 arts-based groups that were run by Upbeat Arts. So there was a choir and there was a creative writing group. There was a range of ages, but the mean age was 46, about half and half male, female. And importantly, the programs were community-based and were facilitated by arts professionals. They were not therapists, they were not health professionals, they were arts professionals. And we went in as sort of independent researchers and did sort of a 3 time point longitudinal assessment. And some of the key measures that I'll talk about next are the participant's sense of identity with the group they joined. So I feel like I'm a tenor in the choir, or I feel like, I've decided that I like prose writing or I like poetry writing. I've now developed this identity as a member of the creative writing group. And the Warwick Edinburgh Mental Wellbeing Scale is a very widely used self-report measure of mental health. So, and this lovely photo shows members of both of those groups who we had a combined picnic day outside of Goma on the South Bank here. It was a lovely day. So we did some multi-level modelling. When I say we, I really mean Elise, obviously my PhD student, and demonstrated that participants' mental wellbeing significantly improved over time, that greater identification with the arts group they joined was significantly related to the increase or the slope of increase in mental health. And the trajectory of improvement in mental health didn't differ between the choir and the creative writing group. So just to sort of put that another way in these 2 panels, on the left, what you can see is scores on the Warwick Edinburgh Wellbeing. So higher scores is better, and then time across the bottom. And in the left panel, we've divided the data up into the high identifiers, the average ones and the low ones. And what you can see here is that over time, the people who are getting the most benefit in mental health, the solid line or the high group identifiers, in comparison, the sort of smaller dotted line is pretty much flat. So if you didn't form that identification with the group, you really got no benefit in your mental health from coming to the group. And the panel on the right is really reinforcing that it doesn't matter so much what you choose to do. So I was thinking as a sort of singing researcher that the choir was going to win, and that coming to choir was going to have all these great benefits. But in fact, the slope is exactly the same. The creative writing people also got those same benefits. And then secondary question to that in the same project was, well, what are the mechanisms? How does this work? How, it's not obvious to everyone that, say, joining a choir is going to improve your mental health. So to answer this, we actually did a qualitative study where we ran interviews with 25 of the choir members and 23 of the creative writing group members at 2 different time points. We just did some thematic analysis on the transcripts, and we found that the arts-based groups influence mental health through meeting these core psychological needs for things like belonging, support, self-efficacy, meaning and purpose, and positive emotions. So I'll give you a flavour of some of the quotes that came out in those interviews. Up the top left, we've got a female choir member saying, belonging. I felt quite content actually, and I felt like I'm part of the choir. And when I first joined, I felt totally separated from everything. And now it's come more close in where I feel I belong. Self-efficacy, this is a male writing group member saying, last week I read this parody and people were laughing, so I felt they appreciated my work. Down the bottom left, positive emotion, a male choir member. I think the songs that we sing are very uplifting and it brings a natural spirit to take away with you each week. Over on the right top here, support, a male writing group member says, you give positive feedback, they feel good about themselves and they feel good about who you are as well, because it's also good for yourself to be able to give that positive feedback to somebody else. Now, for me, this is a really important and profound statement because we've followed up on this in subsequent studies to say that our understanding of social support has traditionally been about receiving of support, but what we're seeing in study after study is that people really yearn for an opportunity to give support to others, to contribute something meaningful. So that was a really nice example of that. And the final one here, purpose. So this is a female writing group member saying, but being part of this group has definitely helped my mental health in terms of giving me a meaningful group to attend. We focus on an activity rather than focus on our ability or disability. So again, this is a contrast between a lot of the support groups that I've been part of and that a lot of people in the mental health services run, you know, recovery groups and that sort of thing, versus something that is around an activity that they're interested in and they're meeting new people, learning new skills, and it's meaningful to them. So that's another really interesting experience there. So just to conclude that study, the participants in arts-based groups show improved mental health across the year to the extent that they identified with their group. And that this group identification seemed to be a foundation through which these other psychological needs can work. So the ones that we just talked about, and that's a couple of the papers that Elise Williams led in that study. So another way of looking at this evidence is through systematic review of existing studies. So in this one, I was really looking at, can these naturally occurring community-based group programs decrease depression? So I did a search for literature in which there was a group activity and then some kind of validated measure of depression over time. And that search turned up 24 published studies that met our inclusion criteria. So 14 of them were randomised controlled, 6 were non-randomised controlled, and 4 were just pre-post evaluations. Of those 24, 10 were arts-based groups, 13 were more physical activity, exercise type groups, and 5 were a bunch of other things, including, you know, garden and horticulture sort of things, as you can see in the image there. And they really were very varied. So the programs ranged in dose, if you like, from 5 to 150 hours with an average of 31 hours in the program and a huge range of different durations. So the average was 15 weeks for these programs. That's just the search sort of selection process on the screen there. And just to say that we crunched the numbers, and the effect sizes on depression of these different community groups ranged from small to very large. And the mean effect size was 1.14, which is large. So in fact, that compares very favourably against a positive response to medication or a positive response to psychotherapy for depression, in fact. We then did a sub-analysis about whether there was any particular age group or any other participant variable or anything about the programs themselves or even about the measures and methodologies of those studies that predicted how big the effect size on depression was. And in fact, nothing was significantly related. And so the takeaway from that is that everyone can benefit from doing a group program in terms of their mood, and that you don't have to go forever. You don't have to join an open-ended thing. You can do something that's maybe, you know, an 8-week program and still expect to see a benefit from that. And that paper is published down the bottom there. And so these are just a couple of examples from a really large body of work, both from my university, but, you know, very broadly around the world, which has become known as the social cure. So this is where the social identity theory of groups has been applied to health and wellbeing sort of, you know, contexts and services and populations. And a lot of that was sort of summarised in this 2018 book, The New Psychology of Health. And so in a nutshell, we borrowed some very well-established theory from social psychology that says part of our identity, how we see ourselves, comes from all of those different groups and communities and collectives that we belong to, and that differentiate us or our in-groups from others or out-groups in various contexts. So you might think of yourself as, you know, I might think of myself as, okay, I'm an Australian, I'm a woman, I'm, you know, a psychologist, I'm a mum, I'm this. So you sort of think of yourself in terms of the intersection of a whole lot of different groupings and communities. And that's those ways of seeing yourself are backed up by the other members of those in-groups, if you like. And groups influence our health and well-being to the extent that we identify with them. So it's not enough to just, you know, I don't know, be a member of a group where you drop in every now and then, but you don't really do anything, you don't know anyone. So you have to actually identify and become a member and be an active member and that sort of thing. And this group identification has the capacity, as we've said in the Upbeat Arts study, to then allow this psychological needs to be met. So that's one part of the story. And then fast forward to 2019, there was on the left here the launch of the Mount Gravatt Ways to Wellness social prescribing program. So it's a large area of about 8 suburbs on the south side of Brisbane. You can see the people there at the launch party with a very large cake. And then another milestone happened in Queensland. We had a full parliamentary inquiry into social isolation and loneliness coming off the back of obviously the pandemic. And so there was a full inquiry with a lot of submissions from different stakeholder groups and individuals and whatnot. So I was definitely one of those people. And there were many, many references to social prescribing in the report from the inquiry. And that was then adopted in full and all of the recommendations funded by the Queensland government. And so what you can see a couple of years later is we're having a statewide rollout actually of social prescribing through neighbourhood and community centres. And that's, I think, already starting to happen. So what is social prescribing? I know some of you will know all about this. Some of you may not have heard too much about it. So social prescribing is a non-medical health pathway in which patients are referred to social activities and services in the community that can improve their health and well-being through mobilisation of community-based assets and people. So there are lots of different models of social prescribing. Some you would probably call signposting, where you just give someone a brochure or tell them about a group and hope that they turn up. But what I'm referring to sort of for the next studies is the full model or holistic model, which involves a linker or a community connector person as part of the service. So in the diagram on the left, which is the handiwork of Dr. Leah Sharman, who was my project manager and postdoc on these studies, you'll see that it starts with the person who's lonely or isolated and recognising those feelings. Then they're referred to a social prescribing link worker. Now, in the original UK model, it's usually the GP that does the referral, and it's a very GP-based service. In the Australian context, that's not necessarily the case. So Ways to Wellness, for instance, takes self-referrals, takes family referrals, people from faith-based organisations, NGOs, anybody may refer into this. Then the person has several meetings usually with the link worker. So the link worker has to be a very skilled person who's very well embedded in that community, who gets to know them, meets with them several times, understands what they're interested in and what their needs are, and then together they come up with a plan, a social prescribing plan. And that is to help them to embed in one or more activity, social group in the community. It also might be activating social services as well, depending on what their needs are. And importantly, the link worker will follow up as well and not just sort of leave it at that, but make sure that there's a good engagement. And if that's not a good fit, then they will keep trying until they find something that meets the needs of that participant. So you can see here in the rhetoric that we've shifted quite a long way from that sort of psychiatric hospital model of what's the matter with you, let's fix it, to what matters to you. And it's very client-centered. You're sitting down and getting to know the person, and it's a very bespoke model. It's not one size fits all. You actually have to start with the person and then work outwards. So the link worker identifies and helps the client to remove barriers to community connection. So I'll just give you a short overview of the evaluation of this first South East Queensland social prescribing trial. It was a 3-year longitudinal evaluation, but because of COVID, it ended up being an 18-month one for obvious reasons. But we did get there in the end. We finished, and we've been publishing out of it. So there's a couple of open access papers already if you're interested. So in this study, it was a controlled study, which is still quite unusual in the social prescribing research body. So there were 140 people referred in, of whom 114 consented to be part of the research. We had 63 start in the social prescribing arm, and we had 51 that were our comparison group. So this was not randomised. This was a parallel comparison. And they were frequent attenders at GP surgeries in the two same areas. So one was down the road from the Mount Gravatt Ways to Wellness Community Centre, and one was at Inala Primary Care, which was another one of our sites. We followed them all up at 8 weeks, and then right at the end of the project, we had enough funding left to do a longer term follow-up on as many of the social prescribing folk as we could track down. So we did find 30 of them at the 18-month follow-up. What did they get referred into? Well, a whole range of things. As you can see there, support groups, community groups, social clubs, physical activities. There were, you know, aqua aerobics and gym, and there were choir singing, creative arts, classes, education classes, online groups, so a whole range of different things. And the link workers really, I have so much respect and credit for them, because they work so hard to find something that's going to work for that person. So I know this is a very busy slide, but the snapshot is from the 18-month follow-up report that Leah Sharman led. So what you can see down the left-hand side here, the smaller arrows are the 8-week outcomes, which really were quite small and modest. We found some significant group by time interactions for loneliness and trust, but really nothing else at that early time point. But by the 18-month, you've got the larger arrows, and you can see that really across the board, a big drop in loneliness, drop in psychological distress, increase in perceived health, increase in trust, increase in wellbeing. So everything was sort of tracking in the right direction, and fairly significant changes for those participants. This next study was led by Sean Hayes, who was my PhD student, but is now Dr. Sean Hayes. And he was also interested in how does this work and really understanding the experience better. So this is based on in-depth interviews with 15 link workers and 15 clients who were part of the social prescribing. Again, this is applying that social cure, social identity theory perspective. So we're really looking for evidence of how that might explain how to implement social prescribing. So down the left-hand side of this table are the three big themes that came through in what people were saying. The first one was about breaking down barriers. So as we were saying, the link workers are doing hard work, working out what is it that's holding people back from community connection. And they're really big barriers, things like, you know, overcoming anxieties, feeling safe, building enough confidence and competence. The second theme was finding fit with others. So not only identifying a group you might be interested in, but when you walk in, are you the only person of your age group? Are you the only Pacifica person in a room full of white Australians? You know, you've really got to go in there and go, I'm interested in doing this activity, but I just don't feel like this space is where I belong. So all of that is actually really incredibly important for the success of the engagement. And then the third theme was about rebuilding a sense of self. So again, when you've got people who've been quite isolated, they may be not participating in paid work, they may not have family lives, joining a group that's meaningful, that they engage with and they start to thrive, means that they can really pull out all the other aspects of themselves and you know, find that personal growth as well. So that's a really nice outcome there. So this stuff has never been seen before. It's hot off the press. So this is from the very recently released one-year report from the Brisbane North Primary Health Network evaluation of the Footprints Communities Social Health Connect program. So again, Leah Sharman was leading this work. So this was 1 year outcome. So during that 1 year, the first year of that establishment, this is a large area on the far north of Brisbane, so Caboolture, Kilcoy, and out to Redcliffe on the bay. So in that time, 107 clients were referred in. You can see quite a big age range. You can see there were somewhat more females again. A little bit better in terms of attracting, you know, sexual minorities and as well as Indigenous Australians. We actually had none in our previous Southeast Queensland trial, so that is sort of a small but significant step. 100% could speak English, although some were English second language in that group. So we did a bit of a better job. We'd learnt from the earlier study, and we really wanted to know in a more systematic way what were the barriers to social engagement. So here you can see the prevalence of these different barriers that people spoke about in this survey. Mental health was the massive one, 71%. physical health is a barrier, even practical things, transportation, poverty, unstable housing, domestic violence. And then you still see these psychological ones pop up. So lack of confidence, mistrust, those sorts of ones. So, these are very real things that put people off being able to get to those community assets that you hope that they will engage with. And there were lots of outcomes that we gathered. We actually trained the link workers to collect these outcomes, and we did some co-design, and they really liked this wellbeing star. They were used to using it, and they found it helpful to feed that back to clients. They really sort of liked the idea. So that's the bit that I'm showing you, but there are other outcomes as well as part of that project. What you can see there is that all the different domains, like feeling positive, looking after yourself, managing your symptoms, being able to do some work or volunteering. They get a score when they come in, which is in the blue, and they sort of put a circle around it, and then they do another score as they're leaving the link worker-based program, and that's the sort of pinkish line. So you can see that there's been a shift for this particular person. So social prescribing is happening, and it's starting to spread all around the world. I think, the NHS in England has sort of put a lot of funding and has rolled it out quite quickly. It's also going gangbusters in Canada and in various countries in Europe. So I'll give you a little bit of a flavour for what's happening in sort of the global space. So this report on the right is the most recent update to the National Academy of Social Prescribing, or NASP, report on social prescribing around the world. So at this point, there's an international community of practice with over 32 countries that have joined this. And we have our own in Australia. It's free to join the ASPIRE, or Australian Social Prescribing Institute for Research and Education. There's a Canadian one, as I said. There's Recitas, which is actually a collaboration across 8 different countries that are interested in nature-based social prescribing. There's other collaboratives around arts-based social prescribing. So if you start digging into particular types of ones, there are different organisations that are around those particular versions of it, if you like. So as Claire mentioned, I was fortunate enough, myself and J.R. Baker, who's the sort of chair, I guess, of Aspire, because Aspire has only fairly recently been put together, we wanted to go to the UK and learn from people who were much further on in their journey with social prescribing. So we kind of invited ourselves along to a bit of a study tour in November last year. And we met with 4 different hubs where there were lots of social prescribing projects and research going on. And before we went, I'd made contact and I'd sent all of these groups these 4 questions that you see on the slide. And I wanted it to be a knowledge exchange where the Australian people would answer these questions and the UK people would answer them. And we had a number of workshops and followed up afterwards. So you can see there are 29 people involved in this paper, which has been revised and resubmitted, but it hasn't been published yet. So hopefully in the next month or so. But these were the questions that I felt would draw out some perspectives on where are we at as a field, and we have so far to go. What are our key sort of targets and what's on the agenda? So I won't sort of tell you all of the perspectives because, that would take too long, but I will give you the sort of final recommendations, which there are these 8. So the first one was that there's a lot of piecemeal work going on in social prescribing where you only get one measure or one person's perspective. And so there's a real need to draw together these multiple stakeholders, referrers, participants, community group facilitators. They all have a voice, they all have a perspective, and you need some kind of system theory framework to make good sense of all of that. It's really clear that the methods need to be developed in collaboration with your stakeholders, your participants and your service providers, or co-design phase, because it has to be fit for purpose. We actually went through quite a lot of redesign after we launched because of partly COVID, but also we were way too ambitious for the kinds of people that were referred in. They just needed something much, much simpler. And so you need to be aware of those things and probably do it first before you actually, get your ethics and everything. The third one was that a core set of outcome measures would be really helpful across jurisdictions and different projects, but to be complemented by specific measures of whatever framework and key questions you have for your different place. So there's room for there to be very bespoke things, but it'd be really nice if we had just a couple of, minimum data being collected to benchmark across different projects. Factors at multiple levels should be included to ensure a comprehensive understanding of the experience and the value of social prescribing. We had quite a lot of debates around, there's not enough economic analyses of social prescribing, and partly that's because if you do a full economic analysis, it's incredibly expensive. So a lot of the work so far has been quite small budget, and the economic analysis would cost 10 times that much. So people were saying, but that's about cost. But what we're looking at is the value to people, the value to the referrers, because they're getting better services to their clients, the value to the clients because they've got a bigger range of options, the value to the community organisations because they're being able to reach more people with what they do. There's a lot of value there that is not necessarily captured with just, a cost benefit sort of analysis. Funding models should ensure that community sector organisations providing those programs and services are well supported. So this is a massive problem across the world. In the NHS, there is funding, but it stops with the link worker. So the poor people in the charitable sector and the arts workers and whatnot are saying, well, we've got all these new referrals and we've got the same amount of resourcing, which is not much. So this is a massive problem that is being sort of, very much highlighted at the moment. Us as social prescribing stakeholders need to advocate for equitable funding through dialogue and knowledge translation. So things like what I'm doing now and going to conferences and workshops and talking to people, because the people who make these decisions, the policymakers, the government ministers, whatnot, they hear from everyone. They hear a lot of things. They don't necessarily get it unless you're there, sitting at the table and explaining how this helps, Future research could focus on understanding barriers and enablers of engagement in social prescribing, particularly in marginalised populations. So there are some really good projects, both in the UK and Canada I can think of, where they're reaching very hard to reach populations, very underserved populations, very culturally diverse, etc. We still are only at the beginning of that journey here, I would say. Future research should focus on link workers and community workers, so the people facilitating the community groups and their experience, because what we've got at the moment is mostly around participants, which is great, but you kind of need to understand how does this work for the other key people. And of course, coming closer to home, coming back from the globe and coming back closer to home, we have to recognise that we didn't discover this stuff. There have been people here doing holistic health for a very, very long time. So Aboriginal and Torres Strait Islanders are leaders in holistic health care. And actually, when you think about, these new ideas around social prescribing, they're all really closely aligned with, aspects of the social emotional wellbeing model. So connection to country is exactly the same sorts of ideas as nature-based prescribing. Connection to family and community, connection to culture, connection to physical well-being. It's really well aligned, and I look forward to a time when we have renewed understanding and renewed sort of respect, I suppose, for the people who've sort of been there the whole time. And so just since we're talking about the arts and culture, there's a couple of recent papers about cultural determinants of health. This one down the bottom here from our good friends over at Griffith University, so Professor Naomi Sunderland and Bridie Lee Bartlett and their group doing some great work on music as a determinant of health. So I guess to wrap up, where do I see social prescribing fitting within health and social care? It's an interesting question. It was really nice to have this opportunity to try and sort of think about this and articulate it to I guess, an interested audience. I think that it has a huge role to play in prevention, in health prevention and protecting our well-being. That really, if we were thinking about it in the same ways as other public health messaging about eating how many serves of fruit and veggies, or doing so many minutes of physical activity in the week, if we were all doing more cultural and arts-based creative practice every week, I'm sure we would really protect our health and well-being. So, I really credit the work that people like Christina Davies is doing over in the Good Arts, Good Mental Health program in Western Australia at the moment, trying to bring in the idea of 2 hours a week of something artistic and creative is going to be better for your mental health. I see it also as being an important part of holistic health within acute care settings. So if you're in hospital during an episode of treatment, it should be equally a part of your program as the medical part and as the psychological part. The social part has had lip service and really needs to be much more strongly, respected as part of that healthcare. And then I see it as having a really strong role in that aftercare, that sort of re-entry into community recovery period. You might have had an accident or an injury or a diagnosis. All of these involvements in the community and something that's meaningful to you is going to keep you healthy and well out of hospital, which is kind of what health is about. So, of course, nothing you've heard today has been a solo act. I've got a lot of really great students and colleagues. So some of them are on the screen and named there. And, of course, some amazing organisations that we've worked with. Upbeat Arts, who I still work with, and they've been going longer than 10 years now. Primary and community care services at the Gold Coast. They're also in Sydney. Anala Primary Care, of course, the Ways to Wellness, Mount Gravatt Community Centre, Brisbane North Primary Health, and Footprints, and of course funding from the ARC. And I think that is it. Thank you.
Oh, I feel like we should be in a room and everybody should be able to actually give you the round of applause that you so thoroughly deserve, Jen. Thank you.
I'm going to stop the share so I can see your lovely faces. There we go.
There's a few little hands of applause in that sort of silent, Zoomish way. But thank you so much for showing us all just how thoughtfully and insightfully you approach this work and make the evidence around social prescribing accessible to us and also exciting on an intellectual as well as a social level, and so helpful to see that wonderful trajectory. We have a beautiful large amount of time.
Yes, I tried to keep it a little shorter because I really think the best part is the question and answer part. So hopefully we've got some willing takers.
100%. So it is question time. You can put your question in the chat. You can raise your Zoom hand, and I am going to start by inviting Martha Orr, who is a new and fabulous member of the Arts Health Network New South Wales ACT. Jen is an extremely valued member of the Arts Health Network Queensland, so some of our connections in this Zoom room come from those networks. And I actually, before you speak, Martha, I will just take that moment to invite those on this Zoom. If you're interested in arts and health in particular, our two networks have social media presences, and we really try and use our social media presences in order to try and support the work of knowledge translation and to let people connect with each other and find events and so on. So please look us up and follow us and get us in touch those ways. Anyway, so Martha has just been the most amazing force this year in the Arts Health Network New South Wales. Martha, over to you.
Hi, Martha. Oops, muting.
You're on mute. You're on mute, my friend.
Yeah, sorry. Such a fantastic presentation. Thank you so much. I'm really interested in what you might kind of think about the sort of training and support needs of the community arts and cultural practitioners who are involved in delivering some of these and facilitating some of these programs, and what existing resources we might have and how we might build.
Yeah, no, that's an excellent question, and one that I've been thinking a lot about. And also my colleague, Associate Professor Melissa Forbes, who's on the call, has been doing a lot of great work in this area. Look, I think it's varied. I don't think that, you know, like you'll have some people who are perhaps, you know, arts professionals who are incredibly skilled and have been working with different health populations or disability populations or aged care or what have you for many years and are actually incredibly skilled at knowing what to do. But you'll have others who have mainly maybe come from a more educational performance background and who are pivoting across into sort of health and wellbeing, and it can be a bit of a steep learning curve. And so I would like to see more training options. I know there are lots of people starting to do this. So in Queensland, the Queensland government have, as part of the funding that came off the parliamentary inquiry, they've actually commissioned the TAFE Queensland to develop link worker and facilitator training around health and mental health. You know, I think there are already, you know, Uni of Southern Queensland is running a whole degree course. So there's different sort of levels of training depending on what people feel that they need. At the moment, the only accreditation I'm aware of is for the actual professionals. So there is an accreditation framework for art therapists and music therapists, for instance, but there isn't for community artists as such. It's quite a sort of open field at the moment. And I think there's positives and drawbacks from it staying that way. I probably wouldn't want to advocate for us all over-regulating in the way that the health professions have been. And, you know, I teach into clinical psych. It's got just endless amounts of regulation and hurdles and things, which means that you've only got a small workforce being developed because it's just so incredibly hard to meet all of those criteria all the time. So I think, you know, the community-based workers already have a lot of skills and a lot of expertise to bring. So you don't want to assume that they all need particular types of training, but it would be nice if there was sort of some modular, you know, do-it-yourself at home, self-paced sort of training for particular populations or particular types of context. So if you've not worked in a hospital before, or you've not worked in, say, disability services before, that I think would be really helpful. And I think that you know, if there is a funding model for social prescribing, then this kind of infrastructure is going to come online quite quickly. Great question.
Yeah, awesome question. I might just put a link in the chat to the Creative Recovery Network's report, Creating Well, which talks about those issues in the context of where community artists are often step up to support their communities in disaster contexts, but that can really expose those people to, among other things, to enormous mental distress and burdens themselves. So it's really
exactly right. Exactly right.
Approach.
Yes. You know, and as a health professional, we have really strong expectations of having, you know, training and accreditation, but also weekly supervision and peer support. And there's a lot of that mentoring and sort of debriefing opportunities that I don't think at the moment really, there's no structure around that, as I understand it, you know, with the community workers. They're often quite isolated themselves.
Fareshte.
Thank you very much, Jen. And it's lovely to hear your presentation. I was a few minutes late, but I was reading your paper and I got into that paper so much that I missed the beginning of your presentation. And just wanted to say that it was so inspiring because I'm so tired of applying for funding in this field for different groups of patients. And every time I'm so disappointed. I'm just like, no, then someone so inspiring is there and the great work you have done is amazing. My question, after all that I've said, is the link workers. Who are they really like in terms of requirements for a good link worker? For example, NDIS has, I think, case workers, and one of our consumer advisors was saying that they have made their life so easy by connecting them to the healthcare professionals and linking them all. But within this context, who is that person and how can we find them if there isn't training there?
Yeah, no, that's a great question. So we have published a paper that Leah Sharman led about link workers in Australia. So we tracked down sort of all the link workers we could find. This is a few years ago, and there were 15 of them. And we just found out, you know, who are you? Exactly what you've just said. What's your background? What's your training? What do you do in your role? What do you feel you need in terms of supports and training? And so we put that together in a paper. And honestly, it's very mixed. So some of them were health workers that were redeployed into link worker jobs, so like social workers and nurses. But then others were just from the community. So they might have been business leaders or more, I can't remember off the top of my head. I think we had, some people who were from more general kind of community service roles that were then into this link worker position. So it is mixed. And I think the key, so the way I made sense of it is that you don't need to be a health professional to be a link worker. You need to be interpersonally skilled. It's a relational pathway. And I think a lot of people have those skills. And so it opens a door to a lot of people to be link workers. And it means that they can be spread through into rural and remote areas much more effectively because they're already embedded in those communities, as are the arts workers. So you will find the music teacher and the drama teacher and the dance teacher in all of the small, you know, country towns. And, you know, that's fantastic that resources are there. We just need to sort of really connect the dots, I suppose, and also get the health pathway going and have it really recognised by, you know, the nurses and the GPs and the health professionals. Yeah.
Very helpful. Thank you.
There's a comment in the chat that most Victorian councils now have a community connector role. In proof of what you're saying. And a question slightly higher up in the chat that inquires whether any Medicare item number might be in the pipeline.
Yeah, so look, I think that makes really good sense. And I wrote a whole NHMRC application around that, of building in link workers to the chronic disease care plans that you get under Medicare. Didn't get funded, so I can't tell you any more about that story. But there was a whole feasibility project at the national level, and they were looking at lots of different funding options. I don't believe that the department, you know, DOHAC have actually endorsed any of them at this stage, so it's still a bit of an open question. And what you're seeing is a whole range of different things happening in different jurisdictions. So Victorian government, Queensland government are doing some quite strong things through departments of health and communities. PHNs are rolling out trials in different jurisdictions from the sort of the federal funding. What I guess I wouldn't like to see is that there's a lot of enthusiasm and then everything just stops, you know, like at the moment we're still quite vulnerable to that scenario because there hasn't been a single financial support model that's been sort of rolled out yet. So, and of course, local councils have got a really huge role because of their connection with parks and libraries and, you know, community spaces that obviously lend themselves to this sort of work.
So watch this space and be hopeful.
And talk to your local members. We all need to agitate, you know.
Yeah, and don't underestimate the effects of that, actually. I feel like that actually can be extremely effective. And you'll be able to link to this very video pretty soon to show how beautifully it can be set out. And just in case anyone's interested, I tried to put links in the chat where I could. So Jen's paper on link workers, I think I found it, Jen, it's in the chat as well.
Thank you for that. You're much handier than I am.
But you speak and I have time to go retreat.
Can't talk and click at the same time.
No, I can't do that either. Melissa.
Hi, everyone. Thanks, Jen, so much. Great, really great presentation. You mentioned in those recommendations from the paper that's coming out soon about, you know, the community assets not being funded, I think, in the UK system. What other things can we learn from them? Because they're so much further down the track than we are. Like, can you speak to that?
Well, we just need to give more money to the community. That's what we can learn.
Yeah, in terms of other issues with
science.
In terms of other issues with how social prescribing has been rolled out in the UK, though, are there other things that we can learn from apart from that particular example?
Yeah, well, I think that it's probably down to the policy and economic people, and that's not me, but I feel like the modelling I've heard about that seems to be most workable on the ground, but also best value from a sort of government budget perspective is ones where the money goes with the person. So, you know, you might get a voucher for a certain program or something like that. So the money goes to pay for the program, but it supports the person. So look, I think probably a mixed model is going to be the most feasible, where there's some national structures and some Medicare involvement in terms of the referrals, but there would have to be something that goes with the person to the community. So if anyone wants to ask, that's what I'd tell them. But I'm obviously not in those sort of halls of power at the moment. So I feel like my role is more about feeding evidence into those people who know who to talk to at that level.
Yeah.
And perhaps we need, you know, a little bit further down the track, maybe we need another conversation of this kind with the health economists who can talk to us in a way that allows us all into that conversation to weigh the pros and cons of what
different funded models
might actually
and
look like.
You know, I don't think there's no funded thing. Everything's under scrutiny. You know, there's always going to be positives and negatives from any funding model, but we need something to start, like, you know, for this to sort of really get a go on.
Yeah. I don't see any other hands up or questions in the chat, but if there are other questions, now is a good time to ask. And while you are thinking about it, I might invite you, Jen, to talk about different models of social prescribing in Canada, because I think we both share an admiration of how the director of the Social Prescribing Institute in Ontario, Kate Mulligan, has approached thinking about social prescribing and the forms that it can take, and in particular, the ways in which it can contribute to what I might in other contexts call community development.
Yes. So my understanding is that Kate actually is from an urban planning and geography sort of background. And so she thinks about it quite differently in terms of, community assets, community development and community spaces, and then what brings people together, which is quite a different starting point from, say, a health professional starting point, which is where I came from, or, you know, a community sector pathway. And I think that she's also got some really lovely links in with, you know, Canadian Aboriginal groups and thought leaders, you know, who are doing great work in, I guess, bringing their ideas into a more social prescribing landscape, if that makes sense, and sort of working together on, you know, how does this work? And it's very broad. Even some of the examples she gave in, I think when she was a keynote from the first Aspire conference out here, she was talking about a group of, you know, Aboriginal people getting special permits to prepare their traditional food, which was sort of, you know, no one else could have a license to kind of capture these native animals, but they had a license to prepare their traditional food to bring it into the hospitals for the older people who are in hospital. And it made such a difference to them from the hospital food they were getting to this recognisable, very nutritious kind of, you know, cuisine that they were used to. So just, you know, that sort of stuff is really exciting and really innovative, and I would like to sort of see more of that happening here, you know, because we've got such great opportunities to do similar things, I think, here.
Yeah, I do too. And we've got a lot of groundswell that we can make use of actually for those sorts of initiatives. Melissa.
Yeah.
Hi, Genevieve. Thanks for the presentation. It was really informative and inspiring.
Thanks.
I just had a question about, you mentioned with the collecting the feedback and data that you'd like to see a couple of standard things that were collected across, you know, all of those places. I just wondered what those things would be, or what you think the most important.
Look, if you'd asked me that question 5 years ago, I probably would have given you a different answer. But right now, I just read a paper today where they literally only collected one measure of 4 items, loneliness, UCLA version of the UCLA loneliness scale. I thought, oh my God. I've been a bit overambitious in the past, but so look, I think less is more with anything where you've got people who are distressed and, you know, marginalised and you know, they just want to do their thing. They don't want you to stick a survey in front of them.
Sticker filling out forms.
Exactly. But, you know, to get evidence, you do need to have some data at some point. So it's a bit of a walking the line. I think there's a lot of operational sort of process level data that we can capture and use. And it's great when the link workers can be trained to do that. So just even referral sources, number of attendances, number of GP visits, where do they go to, what sort of groups, et cetera, et cetera. A lot of people find it easier to tell a story than to fill in a form. So you can get a lot of information from just asking people, having focus groups. How did that go for you? You know, and just leaving it up to them how long that goes for. So, you know, I think adapting the methods to suit the questions, but also the population is really important. Probably my key set to try and answer your question would be there's a new measure of social determinants of health that is being developed and validated by Candace Oster's group in Flinders Uni. It's called the Steps to Better Health. That's an excellent one. It's visual. It's very easy for people to put a circle around a sort of sliding scale, and it talks about everything to do with, you know, there's obviously social isolation there, but there's things to do with housing and food and connections and work and a whole lot of things. I think that's something that you want to see shift with when people engage with social prescribing. And then I'd probably be putting in some questions around, you know, the meaningful life, the connected life, what matters to you. And there are some just short number of items from the Office of National Statistics in the UK that pick up on those more flourishing meaning of life type of measures. And I think that's probably it. That's probably all you need. And people could probably do that verbally, even if they weren't really that happy to do it on a piece of paper.
Awesome. Thank you. And that was that Flinders University you said with Candace?
Yeah. So if you can't find it, it is published, so the validation of that measure, but it's still they're still developing it further. So it probably best to just email Candace and ask if you know, what the latest version is.
Yeah, no worries. Awesome. Thank you.
I thought I might just invite you to reflect a little bit on the social prescribing that was held in Sydney. It's not that long ago, and it might be nice for people on this call to hear just a little bit about what it was like and what you thought about in terms of what's happening in Australia in the social prescribing space now.
Yeah. So, I mean, I got to hang out with some excellent people like yourself and Melissa and others that are on the call. So look, for me, I was only in one stream, which was really all the arts and culture sort of part of it. And there was a whole other stream of things that I missed, which I would have liked to have seen, which was all about co-design and measurement issues and things. But look, I felt, because I've been to conferences in, you know, in my profession, so sort of psychology type conferences, and this conference in a way, it's very interdisciplinary. So you're getting people who are coming in from, say, urban planning and green space type backgrounds. You're getting people who are interested in lifestyle medicine and sort of, you know, increasing people's physical activity and that sort of stuff. And then you got people like us who are interested in the arts and culture, and, you know, so it's a real mixing pot, and it's a very collegial gathering. I felt that people were open to listening and learning and being really respectful of each other's different ways of doing, you know, their work. It was a nice mix of practitioners, people with lived experience, policy people, and then sort of research. So it wasn't all just research heavy. There was quite a lot of actual participation in different experiences and unpacking things and panel discussions and things like that. Yeah, so look, I think there's a lot of enthusiasm for doing things differently and doing things in a more holistic and person-centred sort of way, in both our health system and our sort of broader community care. But and there's, you know, you get this huge high when you go to these meetings, and then you come away and you go, well, I still can't find any funding for my choir, you know. So, you know, there is also the reality that it's hard, and we're all sort of working on, we're all a bit thinly spread and trying to find the next thing. But I think we just need to hang in there because it's going to happen.
Very much, and is happening. That was,
I
agree with her. She says, they should throw money at you, Jen. This is it might. I think surely for your next ARC or MRFF application again, we'll just put a link to this video and then.
Yeah,
Ellen has asked, do you have a connection in your work to time banking?
Hi, it's from me.
Hi.
Hi. So time banking is well, in some ways it's similar to volunteering, but it's based on mutual reciprocity. So people give 1 hour. The time banking kind of varies from program to program, but generally the rule is if someone gives their time in the community, 1 hour of their time to someone, then that's put into the time bank, and then they can actually take an hour from someone else's time.
Yeah, well, I mean,
it can be anything, you know, a music lesson, walking, going for a coffee, teaching someone a skill. It's anything to do with sharing.
Look, I mean, I don't know of any, you know, successful versions of that. I think it's an interesting idea. But I guess what my work has been really focused on is that group identification. And so it worries me a little bit that if you're doing this more bartering individual people, that you might not get the full effects and the resources from identifying with a group that is meaningful to you, that you continue to engage with and feel a sense of belonging with. And, you know, it's a really powerful effect. I know it's hard to bring it to life with slides. It would have been better if I'd brought the choir here to sing for you and you could see it for yourself. But, you know, when people do those things, they talk a lot about it's like having a family. It's like, these are my people. And it's a profound thing. And I guess I would hesitate to think of it being purely transactional, you know, with that whole banking metaphor. You know, time is precious and, you know, there's something to be said for that. But I think you might miss some of those really great social aspects of the social prescribing into groups. It's quite an interesting thing. So something that came up and that is in this perspectives paper from the UK tour is that in some of their very big scale, like they've got Access Elemental is this big database of people doing social prescribing, and they've done some analyses and found that actually only a minority of people in the UK who get referred into social prescribing end up engaged in a group program, that actually the majority just go to the link worker, which is a bit of an issue from the perspective of the holistic model. And it made me sort of sit and think, well, what is that about? What does that say? Is it that people really just wanted to have this sort of trusted person that was meeting those needs and talking them through, and that actually they weren't that comfortable joining a group anyway? Or is it that they tried and it didn't work for them and they just stayed with the link worker? So I'm not quite sure that it's being done in the full model everywhere. And again, then it comes back to, well, what are the active ingredients? You know, what are people actually looking for? And I'd say that's probably a diverse range of things.
Yeah. Well, I think I have to say I am a link worker. And
okay.
I think, people have been socially isolated for a long time. They rarely join a group straight away.
No, that's right. There's a lot of work to be done. Yeah, absolutely. And, you know, for lots of good reasons, it's good that they're getting that work, you know, that they're doing that. Yeah.
And I'm a little bit fascinated to look at the potential applications of the new Radiance framework from Fan and Warren that might help trace out where some of the pathways and barriers are, from where people are located to how and where various activities are situated. And those who are interested, that's just, you know, the thing that's been fascinating me most recently, and I'll put it in the link for anybody else. But it's been that particular paper looks at trying to understand how social inequality predicts people's pathways through programs like social prescribing or through programs that use arts and culture. And for the first time, it draws all of that literature together to present it in a framework, which I found really useful and interesting to explore. I know Jen is nodding because
Yeah.
they publish these key papers that help us.
Yeah, that's right.
Yeah, so I'll put that in the chat as well for those who are interested. Jen, I can't thank you enough for all of your time and all of your grace and all of your insight this evening. I feel like everybody now can understand why we've been so fortunate to have you as a leader in this social prescribing space as Australia starts to explore so many of these opportunities on the ground, and so many people are. And it does feel like a collective exploration where people are eager to share their experiences and to work together to figure out how we can activate, you know, a sort of social cure pathway that works really well in our context.
Yes, absolutely. I do think everyone has a role to play, and we need to sort of really try and work together on this, which is nice. It's nice to be so interdisciplinary and sort of collective about it, which is the ethos of it anyway.
And you've just done such a wonderful job in helping to enable that. So thanks everyone for your company. And for those of you who joined online, we really appreciated that. And we'll say good night now. We're
Thank
delighted.
you for having me, and lovely to meet you all.